Okay, thank you very much. Can you hear me okay? Uh, I'm very grateful to be here. I'm not in the medical field. Um, I work in counseling and mostly do global international counseling. I'm going to talk about a program that we started about 8 years ago called a Mental Health Facilitator Program. I have 5 minutes and I think 5 slides. Uh, Pardon? Oh, I don't know if I'm hitting the right place. Technologically challenged here. A lot of the places I teach, they don't have these things. Okay, got it. Okay. There we go. Okay, so just to start off, the Mental Health Facilitator Program has been taught in 22 countries around the globe. We started domesticating it last year in the United States, January of 2013. The program expands service capacity and it complements existing resources to improve service in communities. So this here, I just want to take just maybe 2 minutes of my 5 to explain. This is a modified pyramid. I know earlier someone said they didn't like pyramids. We've seen a star, so sorry, we do have a pyramid. And, but it's a kind of a 3-dimensional one, which is kind of cool. We've got here at the bottom self-care. And then up here, mental health services via primary care, informal community care. Then moving on up the pyramid, community mental health services, psychiatric services in general hospitals, and at the very top, long stay facilities with specialized psychiatric mental health services. And then over here on this, so you can see this area down here encompasses most of the pyramid. And one of our practices with mental health facilitation is to teach people self-care in the community and also to get community workers trained up, ramped up so they can help people and keep them out of this area up here. And as you can see here, we have stress, distress, disorder as you go up the continuum here. And that's essentially how we teach community, folks in the community about mental health. We don't use a lot of sophisticated terminology. We do use the term schizophrenia, if you will. But we talk about stress, distress, disorder, being balanced, less balanced, off balanced. The only requirements for this teaching program is that a person can understand us. It has been translated into 10 languages, including Swahili, Arabic. We taught it on the Syrian-Jordan border a year and a half ago to train workers to go into the refugee camps. They have high rates of domestic violence, high rates of child maltreatment in the camps, as you can imagine. The other thing here on this side that's really important is the bottom up versus the top down, or the upstream versus downstream, or someone said earlier today, inside versus outside. That it's this is where the work really happens, but without the people from the top giving sanction, credibility to the program, they don't work. So often I'm working with ministers of health, deputy ministers of health to get these programs initiated in the various countries. So, one more thing here. Frequency of need. As you can see here, as you go up to long-term, basically in a lot of low-income countries, asylum care, that the frequency of need is lower, but the cost is higher. And what we need to do is if you do a whole lot more of this, you do a lot less of that. One of the things we've recently done is we have a new edition of the Mental Health Facilitator Program. It is called the Educators Edition. It was recently piloted in the Winston-Salem, Forsyth County Schools in North Carolina. Go through a second piloting this summer in the state of Montana. This program includes basically teaching all school staff, teachers, administrators, cafeteria workers, transportation bus drivers, security safety officers about basic mental health care, basically assessing people that have problems, how to identify it, supporting the person, and getting them referred. The curriculum also includes information about child abuse, how to recognize it, what to do about it, who to contact within the school mental health system, Suicide. Suicide data in the United States among our young people is, as many of you physicians may know, is profound. Bullying, getting a lot of attention. We have information on classroom management. As many as 75% of school teachers indicate that they don't know how to manage behavior problems, emotional difficulties in their classroom. And so we try to help them with that. And then also how to make referrals, consultation, and following up. This program and the MHF are 24-hour programs. Some of you may have read my paper. It says 30 hours. I shortened it by a day for practical logistics reasons. A 24-hour program you can do on 2 weekends. There are like 18 or 20 modules in this class, so you can break it up. There's nothing magical about doing it 4 days straight. So what we've recently done, after my meetings last fall with the National Alliance for the Mentally Ill here in DC, we have a new edition out now. It's the 1 day, it's called MHF ASAP. And this is to teach people in the community basic information about mental health. As you healthcare workers know, about 9 out of 10 people can identify someone having a heart attack, but only 3 out of 10 people know when someone's in mental distress. How much time do I have? And then it has an introduction to concepts and skills from the original curriculum, and it's for community members interested in mental health education but lacking time. So this is something we would also hope to see at some point in the workplaces. Okay, we use a training of trainers model, the TOT model, in terms of outcome research. With program development, there's usually 3 phases. You develop the program, you implement it, then you evaluate it, and we're kind of a little bit past the implementation stage and doing the evaluation stage. We have an outside evaluator at Syracuse University doing outcome study with our work in Malawi and Mexico, and the educators edition is being evaluated in the state of Montana this summer. We're all about delivery, flexibility. The trainers and master trainers we teach, again, this program was developed initially for low income, the middle income countries. And now it's, of course, there are low income areas in the United States, as we all know. It's an independent, standalone training. We've also began infusing it into academic curriculums. The University of Phoenix, obviously out of Phoenix, has 10,000 Bachelor's of Science in Human Services students have had the program infused to their degree, and they start graduating this month in May. And those people have been trained in mental health facilitation also. The resources, challenges in scaling up. Okay, couldn't see that top part. Obviously, we have financial resources. That I work for NBCC International. We're a certification company, NBCCI. There are about a half a dozen of us who've been doing this for the past, since '06. So we have lots of financial constraints. We basically fund these things from grants that we get. The program in Lilongwe, Malawi is very big. They even have MHF clubs in the schools. They have MHF plays, etc., skits. Time constraints. We have a small staff. I'm the co-author of the MHF curriculum. We spent 2 years developing the curriculum with 19 experts in all areas of mental health, including psychiatry, psychology, social work, counseling, and psychiatric nursing. And we also piloted a program 2 different times a year apart in Mexico City. Quality control versus flexibility. We try to do as much quality control as we can. One of our directors, administrators of the Mental Health Facilitator Program is actually here, Dr. Wendy Schweiger. And we try to we do our best we can with that, but at the same time, we don't want people excluded from the program. So it's that balance between good quality control and flexibility. I'm often asked about what about some people that you train that may not be appropriate. I don't think it's happened very often, but the balance is the people who do get trained do a lot of good in these communities. We track the people that get trained on 3 levels, and that's basically our master trainers, and then MHF, the person's actually, actually out in the street. And international adaptability and translation, and I'll just use the term contextualizing here. The program is completely contextualized with the on-ground partner that we have, for example, in Bhutan, where we have a very robust program that has no mental health services. They have 1 psychiatrist for almost 1 million people. By the way, there are only 12, at last count, 12 child psychiatrists in sub-Saharan Africa. Of course, we could talk more and more about child and adolescent mental health, even in the United States. But the contextualizing is very important. We work all that out with our partners before we go in and do the training. And then during the first day, we do a contextualizing component. And the last afternoon of the training, I basically tell the students or the MHFs that we're training, now that you know this information, how do you use it? And then we spend somewhere between 3 and 4 hours actually applying what we've done. And these things have worked out very well. And that's it. Thank you very much.
Thank you. So I think we'll move on to the second panelist, and then we'll have a longer question and answer period at the end. So our next speaker is Ruth Wagman. Ruth Wagman is a director with Rethink Health and associate faculty in psychology at Harvard University. She specializes in the field of organizational behavior, studying and teaching the design and leadership of task-performing teams. Professor Wagman's current research focuses on creating and leading effective leadership teams, especially multi-stakeholder groups, working to transform regional health systems, identifying the challenges faced by self-organizing groups, and the theory and practice of leadership development.
I think that pretty much